Good afternoon, everyone, and thank you so much for joining in today. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's virtual Grand Rounds, which is entitled Updates in COVID-19 and Novel Surveillance Methods. We're so grateful for the sponsorship and support of the California Medical Association and our partnership with California Health and Human Services. Next slide, please. Here are disclosures for the speakers today. Next slide, please. And here's our agenda, which I'll describe in detail in a moment. Next slide, please. Just as a reminder, CME is being provided for this activity. You'll have to fill out the survey that you get upon completion of the webinar and attest your attendance to get your CME. So make sure you do that, and we'll send out the certificates within a week or so. Next slide, please. As the COVID-19 pandemic continues, public health experts, like the ones we're so lucky to have on our call today, are watching vigilantly to try to predict what's to come. This is getting more and more difficult as our testing has moved into the home and many large testing sites across the country have been closed. Along with the traditional methods, several novel techniques are being utilized to understand the dynamics of how and where this disease is spreading. Today, we'll be discussing two of these emerging techniques with the experts who are rolling them out in California. The two are wastewater surveillance and using dogs for COVID detection. I'm very, very excited for our speakers today, and I'll introduce them in moments. But first, we'll begin with our usual update from Dr. Erica Pan, our California State epidemiologist, who shares the latest information we have on the state of COVID-19 in California every month, and we're so grateful to have her with us. Thanks, Sarah.
Great. Good afternoon. Thank you so much, Kim, and good afternoon, everyone. I will go ahead and just launch in. Next slide, please. So again, we'll kind of give you some updates today on overall epidemiology and how we're doing in California. Always want to make sure we include some treatment updates because that really is our latest tool that we're also trying to increasingly leverage across the country. And then also wanted to highlight just another issue that's emerging around severe pediatric hepatitis. Next slide. So this is kind of our classic epidemic curve that I share with you every month. And just to recap for anyone who hasn't seen it before, the blue line is our cases, the orange is our hospitalizations, black is our intensive care unit, and then deaths are in red. And you can see again, our, of course, biggest surge was in the winter surge with Omicron. And then you can see the hospitalizations there. We're still a higher peak and certainly higher deaths than the Delta surge last summer. And then next slide. You can see sort of magnifying to where we are now. So we are seeing an increase again in our cases, but thankfully we are seeing hospitalizations stay relatively level. As you can see here in this graphic, our 7-day average looks like it might be starting to increase just a little bit there, and so we're keeping a close eye on that. Thankfully, deaths are still decreasing, and ICU has been very, very stable. But also, as people talk about Omicron being milder and quote unquote decoupling, wanted to make sure you noted on that previous slide that the deaths overall in the peak were definitely higher during Omicron than during Delta, for example, with such a high volume of cases. And I'll be talking in a bit about the different variants and how infectious they are. So we're really monitoring this very closely. Next slide. And then test positivity, of course, is something else that we continue to monitor. As we're themed today about different kinds of testing behaviors and different data we need to follow, this is still just PCR test positivity. And so this, of course, is going to shift over time, but I think having that trend of consistency of PCR test positivity, looking at previous peaks and valleys, we are at 4.1% and definitely on the increase here. And the rate of rise, as you can see, has been increasing a bit over the last few weeks. So that is something also that can be an early indicator sometimes of waves or surges of COVID-19. Next slide. So the other ways we're kind of looking at, kind of understanding the status of, different jurisdictions and states. The CDC, as you all know, came out a couple months ago with new COVID-19 community levels. And they update them every Thursday. So we do see actually what they're calling medium COVID-19 community level risk in the Bay Area. And that's increased about 10% of our population in that level, and then 90% are still low. And what happened with these levels is they incorporated not just case rates, but actually hospitalization burden as well. Although my understanding is at least some of these jurisdictions moved into this median level, mostly based on case rates and not necessarily on increases in hospitalization. So again, we're monitoring that very closely. Next slide. And what's really interesting is to contrast this with looking at the old CDC community transmission rates, which they still maintain and recommend we use when thinking about high-risk settings like healthcare settings, skilled nursing facilities. And you can see actually a large proportion of our state, almost 2/3 of our population, is actually at very high levels of transmission, and another 27% or so in substantial. So, most of our state is in substantial or high levels of transmission. So there's a lot of virus circulating. And again, this is just we don't get as much data as we used to because of all the over-the-counter testing, and you'll hear a lot more later about what we're seeing in wastewater as well. But certainly lots of transmission happening in the state. Next slide. But as we again monitor hospitalizations and look to the northeast in the United States and other states that had BA.2, the subvariant of Omicron, our team looked at the comparison of California compared with these other states and tried to normalize it sort of the days since BA.2 was predominating and looking both at 7-day average of cases and then weekly hospital admissions per 100,000. And as you can see, thankfully, California has actually remained relatively low in comparison to the trends in these other states, both for cases and even in hospitalizations. We've maintained relatively, we actually went down a little bit and potentially are starting to increase now, but not at the same rates of increases that have been seen in other states in the Northeast. So again, been watching this very, very closely, but somewhat reassuring that our hospitalizations have not increased at the same pace as some of the other states. Next slide. And then what are we learning about other subvariants of Omicron? So I know it's been incredibly confusing. Everything that is in California is still sort of Omicron, but there are subvariants and the subvariants of those variants. So BA.2 has some, as I've heard others describe, sort of the BA.2 is sort of a child of the Omicron as a subvariant, and then there's maybe the grandchild. So we are seeing that increase in California as well. And we definitely have seen some data that this BA.2.12.1 has a growth advantage and is more infectious compared to the BA.2. And it's similar to that increase over from BA.2 to BA.1. So basically a lot more infectious. It's anywhere from 29 to 45% of all cases nationally, and here in Region 9 in the western region of the United States as of the end of April, probably 13 to 20% or so per the CDC models. In our own modeling team, which is projecting to a little bit more recently, we think it's probably closer to half of our cases now are this BA.2.12.1 in California. Next slide. And then the other subvariants that we're keeping a very close eye on as well is BA.4 and BA.5. So you can see here that really the highest proportions of those are in South Africa, where they're certainly seeing a huge increase in their cases right now as well. We again think there's probably a growth advantage over BA.2, similar to the BA.2 advantage over BA.1. And there are cases detected across Europe as well, but they are rare compared to what's happening with BA.2. So we have seen a handful of these in California as well, and are monitoring closely, but so far it has not taken off in the same way as it has in South Africa. As far as kind of monitoring all these things closely, it may be that in South Africa they have not seen as much of these other BA.2 and sort of their second sort of with waning immunity, maybe their BA.4, BA.5 surge is because they didn't have this other competing subvariant in between. So again, monitoring this closely, so far there is no data to suggest there's more clinical severity, even though there's increasingly, these subvariants are more and more infectious, but so far, thankfully, nothing is indicating that they have more clinical severity or higher hospitalization rates. Next slide. And then I wanted to shift gear and just make sure we're talking about treatment, because as we think about being smarter and what are the next tools in our toolbox we want to leverage to really minimize the impact this virus has on our lives and minimizing hospitalizations and deaths. So treatment, of course, is really important. This is a table that we've shown you previously as well, and just to quickly review, there is Evusheld for pre-exposure prophylaxis for those who are severely immunocompromised, and that is still available. There's nothing authorized right now for post-exposure prophylaxis, and we continue to sort of have new but then lose the monoclonal antibodies. And with these new variants, these monoclonal antibodies do seem to be the most sensitive to changes in the spike protein, which is a lot of how these variants are evolving. So we do still have the telovimab as one option, which is of course still an IV infusion, but more and more we have ample supply now of antivirals. So Paxlovid, we have plenty of supply, and then molnupiravir as well. As you all know, I think the effectiveness of Paxlovid is higher. And again, there is no shortage anymore. Early on, these were scarce resources, but now we really want people to know, and you all as clinicians to know, that if your patients test positive, that Paxlovid is an option. And then of course, there's outpatient remdesivir as well, but obviously logistically that's much harder to do IV outpatient. And again, there's ample supply of Paxlovid. Next slide. So what are kind of the ways you can get treatment to your patients? So there is the Federal Test to Treat program launched on early March, and this is the website to find the Test to Treat locator. So this is for the Federal Test to Treat program site. So these are largely pharmacies across the country. The goal of that program is to have a new way for these oral antivirals to be provided quickly to patients who test positive if treatment is appropriate for them. And then this is thankfully supplementing any allocation we get from the federal government to the state of California. These are sent directly to these pharmacies. So these sites must have rapid testing, although patients can bring in their own test results from their at-home tests, and then they can get either in-person or telehealth prescribing capabilities from a physician or advanced practice clinician on site, and then hopefully get those oral antivirals right there. Next slide. And what are we doing here in California to help also augment and supplement that? There's still only a few of those federal test to treat sites, and we know many of you out there are working on this, and that's actually what we really want to emphasize today too, that it's not just about having all that in one place, although that is really the ideal, but if each of us and the health systems and all of you as clinicians can do everything you can to really facilitate expediting each of these steps. So we need to make easy access to testing. And again, thankfully that has been made much easier now with over-the-counter testing and just a lot more availability. And then, but what can you do and what can our health systems do to make prescribing quick? How do patients get quick access to telehealth or ability to talk to a prescriber, updating phone trees, updating online access points for your patients? Those are all things that we hope you are working on in the field. And then how do you get that treatment into the patient's hands as quickly as possible? Can you mail them quickly? Can you, we're talking about working with pharmacies, and some of your practices and systems can hopefully also work on what are the same day delivery services you can do to get meds again into patients quickly, because as you also know, it really needs to be done within the first 5 days or so of onset of symptoms. Really keeping up-to-date awareness of what pharmacies actually have the treatment on hand. And so you can always go to this site here, the Therapeutics Locator, and that actually will show you how you can find which pharmacies are closest to your patients and where you can prescribe those antivirals so that they can go pick those up. We are working at the state level on really augmenting awareness. So our media and communications campaign, we want to continue to educate you all as clinicians so you know how to get drugs to your patients, but also the public too, that they know that, again, we're not a place of scarcity anymore. There's ample treatment, and that people need treatment early to help really prevent hospitalization and serious outcomes. So we're working on communications and as well as capacity building grants to safety net providers. So we're really working on, working on un- and underinsured and providers who are serving our most vulnerable and helping make sure they have capacity building grants to help expedite these things. We're also really excited to share that starting this week, we are launching our Test to Treat program focused again on the uninsured or those who are unable to quickly access via their usual healthcare provider, that our OptumServe testing sites, so many of our community testing sites are going to be able to not only test on site, but have telehealth prescriptions on site and actually give the medication there on site with the the test results and having test to treat capabilities. So we are going to have more announcements about that this coming week, starting to pilot this week and then expanding that, and hope to continue that, again, really focused on our uninsured. And then for other information and resources, please continue to check our COVID-19 treatments page. And you can also email this email here for our clinical algorithm and lots of other resources if you have other questions about treatment. Next slide. And then to shift gears further to what I alluded to, this hepatitis of unknown etiology, severe serious hepatitis in young children. So early on, there were reports of this in the UK and Scotland and Europe, and the World Health Organization has also summarized globally as of a week or two ago the reports that have been seen. April 29th, there was an MMWR about the Alabama cases. So they had actually noted 9 cases between November 2021 and this spring of severe hepatitis in young children. 2 of those 9 needed liver transplants. The median age is 2 years. All of these children were completely healthy, normal children, no underlying conditions. 5 of those 9 were positive for adenovirus 41 in a PCR of the whole blood. And all of those 9 had some other testing positive for adenovirus. There's another May 5th news briefing from the CDC on this and in the Red Book online. And again, this is very young children. More than half that have been reported in the US have had a confirmed adenovirus infection, most commonly this type 41. 90% have been hospitalized, 14% requiring liver transplants. So again, really concerning serious outcomes here, and 5 deaths. As far as here in California, so far we have 9 cases that have been reported as of last week, and we're going to update those numbers weekly. And we have other case investigations in process. So still a lot of unknowns to uncover on this. Is adenovirus, the etiology of this, or it has not historically caused this series of a hepatitis, has caused some GI symptoms, but as you know, a respiratory virus usually. Is this some other, are there some other co-infections? Is this a post-infection inflammation? So I think there's a lot of hypothesis generation that's going on and a lot of study that needs to happen. Next slide. So as far as clinical guidance, we issued a California Health Alert on April 21st, and we're requesting that clinicians report cases of kids meeting these working case definitions to their local health department within 1 business day. Right now, our case definition is children under 10 years of age who have AST and ALT they're elevated, as shown here, and who don't have another identified etiology for their hepatitis since October 1st of last year. And hopefully all of the other sort of usual hepatitis viruses will have been tested for and ruled out already. And then we will then communicate that to the CDC. Next slide. And then as far as lab testing, I think you'll want to be collecting stool and respiratory viral panels and whole blood, because there were some of those Alabama cases, and I think in the UK as well, where they were negative by serum, but when they got, or plasma, I mean, and when they got whole blood, they were able to identify adenovirus in those PCRs. And then if you send those also to our state lab, we will be doing typing and whole genome sequencing to really look at the relationship of all these. So our KHAN has more detailed information about testing and specimen submission, but really want to make sure this is on your radar and just something, again, we are kind of globally looking at closely and trying to understand the etiologies. Next slide. And with that, I will turn it over to Dr. Yu to talk much more about wastewater surveillance and what we're seeing here in California. Thank you very much.
Thanks so much, Erica. I think that was a really interesting presentation, not only because it's always the up-to-date information on COVID, but really for the first time in a very long time, we've talked about something other than COVID. And I think it highlights both the fact of where we are in this pandemic, but also how exciting it is that we have this series so that you can help communicate to all of us on the front lines with the kind of leading edge stuff on this. So now I would like to thank you, and then we'll welcome Dr. Alexander Yu today. Dr. Yu is a public health officer, an epidemiologist, and an adult infectious disease physician at the California Department of Public Health. As a public health practitioner, Alex strives to improve our understanding of infectious diseases in California through enhancement and innovation of surveillance systems. In addition to working on enteric, waterborne, and environmentally transmitted infectious disease surveillance and outbreak investigations, Alex has co-led California's state COVID-19 wastewater surveillance efforts since 2020. Alex did his internal medicine residency at Mass General Hospital and infectious diseases fellowship at Stanford University. Alex, come on and turn on your camera. As mentioned earlier, please submit any clarifying questions you may have throughout the presentation by using the question box in the control panel. Did I say that earlier? Anyway, please do, which is located on the right-hand side of your screen. And take it away, Dr. Yu. Thanks so much for being here today.
Great, thanks, Kim. Next slide. All right, so I'm going to talk about wastewater surveillance, and I'll start with an overview of what public health surveillance is in general, and then try to walk us through how wastewater fits in, including how it works, if it works, and how we use this novel surveillance system. And since I think the system can have practical use for all of you, I'll walk through some resources to see wastewater surveillance data and some nuances when you're interpreting it, as I hope you'll all feel more comfortable in looking at it after this. Next slide. So I wanted to start by taking us all back to early 2020, which maybe feels like a lifetime ago, but it was when we were also desperately learning about this novel COVID virus and states were first starting to lock down, and extremely limited testing meant that our awareness of whether this disease was already amongst us and how widespread it was pretty poorly known. And this New York Times article captured one of the many complex issues at the time, including how a lack of awareness of how widespread COVID was blinded our early response to the pandemic. And here they focus on the limited access and lack of widespread diagnostic testing, which meant that we couldn't test patients, even those who were suspected of having it. And other important aspects throughout the pandemic, but especially early on, included the unknown sensitivity and specificities of diagnostic tests that were coming online, and the realization that there were asymptomatic cases that could spread disease but were unlikely to get tested. And all these combined to a lack of awareness of how widespread disease was. Next slide. And so these issues in essence capture the heart of why public health surveillance is important in some of its complexities. Surveillance is, in its simplest form, the counting of cases for the purposes of situational awareness. And why count cases? So some of the core reasons are to understand the burden and extent of a disease so we can assess the risk and plan for it, but also to identify and respond to outbreaks, as well as to assess effectiveness of prevention or treatment efforts. It's also important because without knowing how many cases there are, we can't figure out important characteristics of a disease, such as what percentage of cases die or how effective a vaccine is. And all this is important for public health, as well as for healthcare and personal decision-making, as well as for resource planning. For instance, knowing that a flu season is starting allows us to ramp up vaccine campaigns. It narrows our differential when we're seeing patients, and helps pharmacists keep the right meds in stock. And also helps at-risk patients know what's going on and whether to go get their vaccines. So most traditional disease surveillance is relying on diagnostic testing. And this means people going to get tested and then those tests getting reported to public health. So what happens when cases aren't tested? The simple answer is that they aren't counted, and this can be for a number of reasons, including lack of access to a test, that people don't want to get tested, or the test simply doesn't get reported to a public health system, such as with home antigen tests now for COVID. Next slide. So wastewater surveillance is a form of environmental surveillance where wastewater or sewage gets tested for a disease. And if you find it in sewage, then it's evidence that there's someone that's infected in the population that's contributing to the sewage. It's a type of pooled sampling method, meaning that a single wastewater sample represents the whole community, since most people poop into the sewer system and all that poop gets mixed together. So what you find in wastewater doesn't represent any one person, but it's like taking a sample from everybody in the community and then pulling it together to test. And this isn't a new system. It was first used almost 70 years ago, and most extensively and famously for polio. Next. So let's walk through how this works for COVID. So about half of infected people, both symptomatic and asymptomatic people, will shed virus in their stool. Next. This then gets flushed down a toilet, and within hours to a day, makes its way to a wastewater treatment plant. Next. The sample of wastewater is then collected by the utility and then sent to a lab where the concentration of dead SARS-CoV-2 RNA fragments are then measured and reported to public health, where it can get analyzed and used for surveillance. Next. And how well does wastewater work? So here are case data from the last year and a half of the pandemic from the San Jose sewer shed. And you can see the distinct peaks of each of the last few surges. So starting in January of 2021, or the Alpha surge, and then in the summer, the Delta surge, and then the most recent Omicron surge. Next. And here now are the concentrations of SARS-CoV-2 virus in wastewater from the San Jose sewer shed over the same time frame. And you can see that the trends and the amplitudes of the wastewater match up really well with the case data. Next. If we formally compare these, we see that the correlation between cases and wastewater over time have been strong. They've also been positive and linear. And this is a comparison of the log wastewater concentrations versus log incident cases in each sewer shed, with wastewater on the y-axis and the cases on the x-axis. And the closer that these dots get to the line down the middle, the more perfect the correlation. So here, for each of the main California sewer sheds we've been monitoring in since January of 2021, we can see the dots all cluster around that middle line. And the Pearson's correlation coefficients range from 0.7 to 0.95, all of which are very strong. Next. So another important question is whether wastewater acts as a leading indicator. And during the Omicron surge, wastewater did provide a leading indicator as compared to case counts in some, although not all of our sites. And these are data from our Southern California sites. So LA County, LA City, and then Orange County. And the top here is wastewater and bottom is case counts. If you look at the bottom row, I've placed the blue dotted vertical line when case counts first started to really rise in each area. And if you follow that dotted line up to the top row in the wastewater graphs, you can see that wastewater had already seen a rise for at least a week and as much as 2 weeks. However, we didn't see this in all of our sites, and I'll caution that I don't expect that wastewater will always be able to give a leading indicator. And it likely varies by sewer shed as well as by surge, and is dependent on a lot of different things. Most importantly is probably how quickly case data gets counted on the traditional case surveillance side, which is always related to a number of different factors, including how long people wait to go get tested, incubation periods, lab delays, or the use of screening programs. Next. So the monitoring of variants through wastewater has also been exciting and have correlated well with our traditional surveillance that relies on whole genome sequencing of case isolates. So here are the relative proportions of the alpha and delta variants in the two sewer sheds, San Jose and Sacramento from last summer. And here alpha's in red and delta's in blue. You can see that in both sewer sheds, alpha had been dominant around 60 to 80% of all the circulating COVID until delta's emergence and rapid takeover around May to June. Next. If we look at the data that's generated through mutation-specific assays in wastewater, we see the same trends and proportions with emergence and takeover of delta in each of the sewer sheds in the May to June time period. And here the correlations are again high, over 0.8 for both variants in both sewer sheds. Next. We're also actively exploring with our academic and local health partners the use of wastewater to monitor for other pathogens. And the results so far have been promising. So on the left are RSV data from a published article by our Stanford colleagues. And on the top, you can see California state positivity for RSV, which started to rise last summer and peaked at 16% in early January. And the bottom is RSV concentrations of wastewater, again mirroring the percent positivity closely. And on the right is preprint data out of the University of Michigan of a campus flu outbreak in the fall. And you can see percent positivity in black and the reported cases are in red. And the bottom is wastewater in blue. And you can see how closely it mirrored the case count and percent positivity. Next. So how do we use wastewater? Next. So as widely being talked about, our current transition and pandemic strategy comes with a likelihood that we'll increasingly not have accurate case counts reported to public health. As this Time article from April says, the rise of COVID cases in some regions of the US, just as testing efforts wane, has raised the specter that the next major wave of the virus may be difficult to detect. In fact, the country could be in the midst of a surge right now and we might not even know it. Next. So we think wastewater helps fill in some of these gaps and can play several useful roles, both at the public health level, but also to providers, health system, and others at the local level. And the primary way includes for situational awareness, where wastewater surveillance can clearly help to provide information when testing data is limited and can give you a gauge of how much community infection there really is that's unrecognized. It can also be used to confirm or refute epi data trends, such as to see if a surge is really happening or not. And it could also serve as an early indicator to help with variant monitoring, as well as variant detection, and to tell us about things like flu or RSV or other pathogens, or for things like antimicrobial resistance. On the public health side, it also helps us to understand virus epidemiology and can also be used for modeling, such as for forecasting or for transmission models. And this situational awareness then directly can inform public health action. And that includes ability to message and to raise public awareness about the state of disease. And unexpected wastewater signals can lead directly to testing to identify outbreaks. Similarly, it can also be useful for resource planning on many levels. So for instance, to ramp up or down resources, including for testing or contact tracing or vaccination, or for sequencing. And it can allow you to focus those resources on specific areas where you detect a wastewater signal. And it can also be useful for hospital bed or resource planning. It can also provide a reliable source of information to which public health decision-making can be made, including for complex decisions on things such as mask wearing. And so for providers, understanding local COVID activity and about new or dominant variants can help inform our and our patients' understandings of infection risk, as well as the likelihood of disease or severity. It can also help inform messaging and answer questions about need for boosters or masks, and change our pretest probabilities for COVID or for other diseases in the hospital. Now, at the clinic, the pharmacy, or the hospital level, it can help with resource allocation. And at the provider level, it can also be important for making decisions about therapeutics based on what circulating variant is dominant, or perhaps in the future, choices on antibiotics based on local antimicrobial resistance. Next. So where can we see wastewater data? So here's our CDPH California Surveillance of Wastewater Systems dashboard, or what we call CalSewers, which is available to all online on our website. And this dashboard shows data from all the sites within our CalSewers network, which include data from our core CDPH sites, as well as sites that are run by our academic partners and those from the CDC partnership. And right now, this includes over 30 total sites, including some from every region of the state. Although some of these sites are just starting to get added to the dashboard. And just to orient you to this tool, once on the dashboard, you'll see a map of California on the left with an outline of all the sewer sheds that are being monitored. And once you select a sewer shed, the top right map shows you a zoomed in outline of the region that's included in the sewer shed. And the bottom graph shows you wastewater concentrations over time. And there you can zoom in and out to different time periods to get a better sense of what's going on in different periods. Next. So I hope you'll take a look at some of this data. And as you do, I wanted to make a few notes to help you with interpreting wastewater. And this is a new and different kind of surveillance tool, and it isn't quite the same as case data or quite as straightforward, despite what I've been trying to convince you of. So I'll start with number one, which is that it's important to look for trends and not focus as much on raw data points. So environmental sample data has a lot of intrinsic variability, and this is true for wastewater too. If you drill down on the dots here in the top graph, you can see a lot of spread with points from day to day going up and down. You can also see there are many outliers, some of them high and some of them low. And these aren't wrong per se, they're expected parts of environmental variability. And so the trends are the most important to show you how things are going. And generally, we like to see several data points in a row that are going in the same direction before we call a trend. If you look at the top graph, the green line is a moving 10-day rolling average, which helps us to see that the overall trend over this time period is increasing, which is really the most important point. The second thing I want to point out is that the actual Y values for concentrations aren't really that useful, and you'll see that for a lot of our graphs, we actually just mask the absolute value. And this is because different labs use different methods and different measurements. And so the absolute values can vary by orders of magnitude depending on what a lab does. And this also means that they're not directly comparable. So I would only look at the raw absolute values if you're comparing data within the same sewer shed that uses the same lab. That said, when you are looking at wastewater data for any one sewer shed, comparing back with old data and concentrations is useful, as it gives you perspective on how high or low a concentration is. For instance, if we just looked at this top graph, we see that the wastewater shows an increasing trend and that perhaps it's rising to a high level now. However, if we zoom out to include the wastewater concentrations from the Omicron surge, as in the bottom graph, we see that the current levels are actually pretty low compared to that. Another point about relative change is that I want to caution against interpreting reports about percent changes in wastewater. If we look at the time period marked with the 3A, you can see that a tiny concentration value can increase by several 100% without actually meaning much in terms of corresponding increases in cases, because you started with such a small number. If you look at the 3B time period, you can imagine that even a doubling of wastewater concentration would actually have massive implications. Next. And one last thing that I wanted to note is that some dashboards will report wastewater data in log scale, while others will report it in a linear scale. And for the most part, I've shown you all data in the linear non-log scale because it compares most closely to epi case curves and trends that we're familiar with looking at. Others prefer a log scale because small changes in concentration aren't as noticeable, and so it can be easier to see trends rather than the noise from environmental variability. There are pluses and minuses of both, but the main takeaway is that they aren't the same. So if you do start to look at these, and as you get yourself oriented to a wastewater graph, pay attention to what scale you're in. Next. So there are a lot of references for you on wastewater available, and I've included a few here. So in addition to our state dashboard, several of our academic partners here in California have excellent dashboards of their own that provide info about wastewater trends, as well as data about variants. Next. So now that you're all used to reading these wastewater graphs, here's some recent trends in wastewater in California. And so overall, we're seeing that wastewater trends are increasing at almost all of our monitored sites in every region. And this has been most pronounced in the Bay Area region. So the first plot is of wastewater in the San Jose area with the most recent 6 weeks of data shown here on the left. And you can see that the trend continues to increase here. And for perspective, on the right is a zoomed out view that shows what current concentrations are relative to the most recent Omicron surge in January, with current levels around 20% of the peak. And on the bottom graphs are Davis and Yolo County, just to give you another example, and you can see similar upward trends. And these mirror what we're seeing in most of our sewer sheds. Next. However, we are seeing signs of plateauing and some improvement at a handful of sites, including in San Francisco and the Bay Area, shown here at the top graph, as well as in Orange County on the bottom graph. And in both sites, you can see that the rises in concentration appear to be tapering off and hopefully are starting to plateau. Next. So overall, wastewater concentrations continue to increase. And this trend started in mid-March and was most prominent in the Bay Area region, but is now true in most sewer sheds and regions. Overall, these regions are still relatively lower when you compare them to the Omicron peak. And for most sites, it's still in the 10 to 20% range compared to Omicron. And we also know that the BA2 continues to be dominant for wastewater, and with signs that BA2.1.21 are likely increasing now, and we think are in the 15 to 40% range, although these data are preliminary. Next. And so in summary, wastewater surveillance for COVID has been really pretty reliable throughout the pandemic, including here in California, as a proxy for community transmission, as well as for variant monitoring. And it's promising as a way to monitor for other pathogens in the future as well. It provides situational awareness, which is important for public health, but it can also be useful at the local level for messaging, as well as risk assessment and resource planning. Wastewater is not a new system, but its emergence as a real-time public health tool is new, and interpretation can be a bit nuanced. However, hope that it isn't intimidating to any of you, and there are many resources and dashboards out there to try out, and so you can get yourself more familiar with it all and to learn more about this data. Next. And I just wanted to say thanks to many different groups of people who've helped make the system possible over the last year and a half, including those here at CDPH, and as well as at the State Water Resources Control Board, and our academic partners who really have led the way in helping make this research and methodology into a surveillance system, as well as the local health departments and the CDC, and utilities whose hard work in collecting and handling these samples have been really, really critical, and who we're very grateful for their service and help in this program. And that's it. Thanks.
Thanks so much, Alex. That was an incredibly rich bit of information, and I have to say it's also just a red letter day here on our Grand Round series, because that, I think, was the first use of the word poop, and my 9-year-old daughter is going to be so impressed. So thank you for that. I have so many questions to ask you, but first we're going to invite our third speaker on, Dr. Carol Glaser, and we are thrilled to have Dr. Glaser to talk about another very novel and very interesting use of surveillance. Carol Glaser is both a doctor of veterinary medicine and an MD. She's currently the Assistant Deputy Director for the Office of the State Public Health Laboratory Director, OSFLD, I think is how you say that. Her formal training includes training in veterinary medicine, as I said, followed by training in human medicine with a pediatric residency and then a fellowship in pediatric infectious diseases. Carol was the only educator who could ever teach me a comprehensive and fail-safe way to remember the antibiotics and what they treated, and for that, I'm forever grateful. However, most of her career has been with the California Department of Public Health, where she served in a number of different roles, including the medical officer of the Viral and Rickettsial Disease Laboratory, the acting chief of the immunization branch, and the chief of the Viral and Rickettsial Diseases Laboratory. Most recently, she was with Kaiser Permanente in Northern California working as a pediatric infectious disease physician, but she returned to CDPH to work on COVID-19 in the fall of 2020. She works with a CDPH testing task force, and she leads the antigen testing program for COVID-19 in the K-12 school setting, a really important program. And she's also leading a pilot program to examine the utility of using dogs for COVID-19 detections in student and staff at schools. So Carol, tell us all about this exciting work, please.
Thanks, Kim. I'm really excited to be here today to talk about this program. And as I go through this program, I'll obviously describe a pilot program we put into schools. It's kind of embedded in our antigen program. But I'm also hoping as we go through this, that you can begin to appreciate of really what I would say is an untapped potential that dogs have to help us in medical biodetection. So I think beyond COVID, there's so many things we can do with dogs. And I think people are, because of the COVID pandemic, this is a bit of a silver lining. We're just, I think more and more human doctors are beginning to appreciate how much we can do with dogs. Next slide. So I think probably most of you know dogs are widely used in airports and by police, whether it's looking for explosive or opioids or even missing people. Scientists often use dogs, whether they're tracking for snow leopards in the snowy mountains or looking for gorillas and koalas, and they're even used on boats to help track killer whales. So their smell is just their sense of smell is absolutely phenomenal. And to give you a sense of what that looks like is if you were to take one drop of a liquid and put it into enough water that would fill 20 Olympic-sized pools, the dog's smell can detect that. So it's something that I think most humans really can't truly fathom how incredible it is, but just I think we need to begin to appreciate how much we might be able to utilize them, particularly in medicine. Next slide. It's been known for years that they have been able to detect cancer, whether that's bladder cancer, lung cancer, breast cancer, and even cervical cancer. Next slide. More germane to this conversation, of course, is their ability to detect infectious disease. There's a famous dog called Cliff who's been trained to detect C. diff in stools. And of course, I would say, that's not all that surprising because even humans feel like they can smell that. But beyond that, there's dogs that have been trained to detect individuals that have asymptomatic malaria. They're specific can be trained for influenza, and then of course most recently for COVID or SARS-CoV-2. Next slide. So importantly, when dogs are trained to detect this, they're not actually detecting the virus itself. They're detecting what's called a volatile organic compound, which is a low molecular compound that's basically, during an infection, it's secreted by almost every organ in the body, and then it's released through our breath, our saliva, the urine, the feces, and in sweat. And you'll see in just a few minutes how we really take advantage of the fact that it's in sweat to actually, we use that to help train the dogs. And basically anyone who's infected with COVID will release certain VOCs that are specific to COVID-19. Next slide. So there's really been, since the start of the pandemic, there's been studies across the globe showing that dogs can detect COVID-19 or the volatile organic compounds released by COVID-19. These studies have been done in France, in Lebanon, Chile, UK, Brazil, and even in the United States. And studies continue to go on today. Next slide. And so about a year ago, when we were putting into place our antigen school program in schools throughout the state, we became aware that very public venues were using dogs, such as in airports and in sporting venues, to sniff for COVID. And we thought, wow, what a great program that would be, because, you know, if we didn't have to have each child swab their nose and to run the test, wouldn't it be great if we could use dogs? So we began to think about it. And of course, you know, people were a little skeptical of this, but we did know that it was being successfully done in airports in Lebanon, in Thailand, and then even in Miami, where they used it in big stadiums, and successfully so. Next slide. And, you know, when you think about, there's so many benefits to be able to use dogs for COVID-19. And certainly that non-invasive technique would be lovely, right? I mean, these poor kids in our schools, they're accepting of a lot of this testing, but I think that they're very tired of having to swab their anterior nares, you know, once a week or twice a week or however often. Certainly dogs could be efficient and effective. They are relatively inexpensive once they're trained. And I think most importantly of all is that they have the capacity for tremendous throughput. We really don't know how quickly they will be able to screen, because we haven't really tested that. But what we do know from our colleagues that work with bomb sniffing dogs in airports, dogs are able to basically test or screen about 300 individuals in just 30 minutes. So this really lightning speed could really change the dynamics. And I think, you know, you have to say, I mean, for those of you who are dog loving like I am, it's fun. And in our schools, this has just been a tremendous ambassador for our testing program. Next slide. So we had actually thought when we started our program, we started the pilot about 4 or 5 months ago, that we were the only state that would be doing it in our schools. Actually, in the last couple of months, we've become aware of 2 other sites that are doing this. They're doing it a bit differently. In Massachusetts, actually, it was the police force that used some of their training techniques, particularly the way they train narcotic dogs. They took those 2 labs. They worked with actually the Florida University, who's got a lot of experience with scent detection. And basically, they trained dogs to detect VOCs. They actually used masks from people that had COVID, and that's how they trained on the scent. And then what they do with their program is they take the dogs into an empty classroom, and the dogs search around. And if they stop at a given desk, let's say it's Johnny's desk, then they'll go and test that individual. So this is one approach. And then Hawaii, they also have laboratories, and they've trained them. And what they do there is, as children enter the schoolyard, basically they're given a cotton swab. They wipe the neck, and then they give it to the professional, who puts it in a box, and then the dogs later sniff it. So these are various approaches. And just in the last couple of days, the group in Hawaii has just published on Open Forum some of their protocols. And we actually have a meeting with the group in Hawaii to sort of change best practices and talk about what lessons learned. And so we're really excited about it. But basically, in both of these venues, it's showing that, yes, dogs can be trained to do this. They're doing very well. And of course, you can imagine schools love them. Next slide. So moving on to our specific program, basically it's funded from the CDC Foundation, and we received the funding in the fall of last year. Next slide. And we obtained 2 dogs, and their dog's name is Scarlet and Rizzo. These dogs were raised as service dogs by the Canine Companions up in Sonoma, and then they were trained, and they continue to be trained by our colleagues in Concord, the Early Alert Canines. Now this group, we actually reached out to this specific group because their specialty is training dogs to alert for diabetics. Both they detect low and high glucose. So it was a bit of a shift for them, but they knew a lot about training dogs and training on a scent. They just hadn't worked with an infectious disease. So these are our 2 dogs. Next slide. And so one of the first things we were challenged with, and again, this was before, we didn't have the benefit of knowing what Massachusetts or Hawaii was doing, is we thought, well, how are we going to get the scent to train those dogs? And so we knew that volatile organic compounds are released in sweat. We also know that there's a lot of people that sweat a lot in their feet. So we reached out to friends and family and friends of friends, and we basically asked anybody who had had COVID-19, actively to donate their socks to us. And basically, over the course of the last several months, we've received over 100 dozen pairs of socks worn by individuals that were infected. These socks were used in the training, the Early Alert Canine Center, where they basically would put them into this 12-arm scent wheel, and they would train the dogs. These dogs went through about 8 weeks of training, and once they were getting it right about 90% of the time, we said, okay, now it's time to transition over to people. Next slide. So then we went to one of our community testing sites where we have a really strong relationship. It's a site funded by the Testing Task Force. And as individuals stood in line to get tested, we asked for volunteers that would come and participate as we trained the dogs. And you can imagine there was a lot of willing partners. So at that point, we were basically taking what the dogs had learned in that lab, and we were training them to people. And then we sort of practiced with them, and we actually knew what the results were as they lined up. Next slide. So the big test was, of course, putting now this into schools, because schools are kind of a whole different mixture. And the huge advantage we had is that we had this robust antigen testing program where we have a program set up where testing is done on a very regular basis. It's all tracked, all the results are tracked by software we call with primary.health, and this particular company helps track all the consents and the test results and what's going on with the individual. So it's a beautiful way that all of this data comes together. And basically, we could just embed this project right on top of that. We did ask, of course, that we asked for schools in the Bay Area to volunteer. And we told them it will be more work. Eventually, we're hoping this is going to be a lot less work, but it's going to be one more thing we're going to ask you to do on top of what you're already doing. We had a number of schools that rapidly volunteered to do this. We also asked that we push out consents. We wanted to get a specific consent from all parents and staff involved. We weren't going to just have students come and line up. And there was a very good consent rate. So once we had all of that set up, we actually went out to schools on whatever day that they were going to do the antigen testing, because we wanted to be able to know how the dogs were performing. So the students and staff would line up, typically outside, and they would face away from the dogs. And the reason they would do that is that as the handler runs the dog, if the dog detects COVID, the dog quickly sits and then moves on. But we were trying to ensure privacy. That's kind of the general way it's set up. And all the students and staff would be tested after they were run by the dog, so to speak, with an antigen, so we could compare the results. When there was a discrepancy, for instance, the dog sat, but the antigen was negative, we asked that a follow-up PCR be done, and then vice versa. We also, in some cases, had a repeat antigen test done. And then I think most importantly, and what's been so popular with the students, is when we were sort of done with the testing, there was an opportunity for the children that wanted to come and pet the dogs, they could come and interact. And the children have, for the most part, just absolutely fallen in love with our dogs. Next slide. So this is just an example of the screenshot that we get. We track these results like we track antigen and PCR. And so we actually track each dog's results. We look to see how Scarlett's doing, and we look to see how Rizzo is doing. And we can track how many tests have been done, how many individual participants, and what the sensitivity and specificity are. Next slide. So basically this is, just yesterday I was just pulling these numbers. I would say that this is the dog's report card. There's Scarlett there and there's Rizzo. We've done now over 3,700 paired antigen and dog screening on over 1,600 individuals at 40 different sites. Overall Scarlett sensitivity is great. It's over 90, it's pushing 90%. Specificity, we're having a little bit of issue with Scarlett. We're still working on that. Rizzo's vice versa, sensitivity not as good, but basically even in the last 2 weeks, both of those dogs are doing much better. We're kind of working on things. We do use antigen as the gold standard, but we absolutely appreciate that in some ways the dogs are better than antigen. There is instances where the dog, we will know that a child was positive a month ago, they're negative on antigen, but the dog will often sit for them. And then we also know that there's just twice in the last 2 weeks, there's individuals where the dog sat, the antigen was negative, but we tested that individual the next day and it was positive. So we have to put those into our numbers. It's not to say every time the dog sits, it turns out to be either an old infection or a new one. There is some other reasons they're sitting that we're still trying to figure out. But overall, they're doing tremendous, and basically it's working out quite well. Next slide. And then we actually took these dogs into some other venues. There was a pre-prom testing in the San Mateo, and basically we took the dogs out there and sort of did that side by side. Very, very popular. We've also used them in a special needs school, and the kids absolutely fell in love with them. You might realize that special needs children can be difficult to constantly be swabbing. So we're looking at how well they interact with those children, and it's just gone beautifully. Next slide. So eventually our plan is that the dogs will be the screening tool. There won't be all this side-by-side antigen, and that the dogs would run maybe a couple hundred students, and that it would only be those where the dog sat that you do the backup antigen test. This would be faster and less invasive than the current testing modalities, and certainly it could be work beyond schools. Next slide. And I took this quote from the executive director of the what is basically the comparable program in Hawaii, and this really nice quote was basically saying that dogs have so much untapped potential to help people, especially in the field of biodetection. We're just beginning to understand what they're capable of. So I guess if you take nothing away, just keep in mind the dogs are just their sense of smell is so amazing, and we should be utilizing them more. And I would also say that just the popularity of this program within the kids at schools, I mean, the kids are tired of the testing, but boy, they're not tired of the dogs. And I think it's really a way that we can continue to test and not have such a negative impact on our children. Next slide. And just like Alex was saying, he has a lot of people to acknowledge, this has been a tremendous team effort. The whole testing task force, particularly the antigen team, particularly with Chloe, Leah, and Rob, folks at UC, the Virus Lab, Early Alert K9, the Foundation, American Public Health Lab Association, and of course our pilot schools. This has been a tremendous amount of work for the schools that have piloted with us. And then just last slide, and I'll just end. Then we do have what are comparable to baseball cards with Rezone Scarlet's name when we go out to schools, and the kids love collecting these. Thanks, Kim.
Amazing, Carol. That was one of the most exciting presentations we've seen, and such an incredible and innovative way to use these tools. And I think that most people would really respond well to dogs, but particularly for children for whom this kind of testing is just so profoundly difficult, as we know as members of the community and parents and things. So I am thrilled to say that we've had 3 excellent speakers today, and we only have 2 minutes left. Alex, can you pop on? I'm going to try to get one question out of each of you guys, or maybe, and we have so many good questions today. Those are going to have to be paused for another time. But Alex, some people were just asking 2 quick questions, if you can answer quickly. One is thinking about the pros and cons of this novel way of detecting all diseases, but particularly COVID. What's the cost compared to traditional surveillance? How does that sort of balance out?
Yeah, that's a great question. I think it depends a little bit how you think about the question. The per sample cost is pretty marginal. It's probably, if you were to use a private lab, it's somewhere in the $300 to $1,000 range for a single sample to get tested. And that includes like the shipping and all the supplies that you might need. And so, we do this generally 3 times a week per site. And, a single site might represent all of the city, which is, several 100,000 people. So it's pretty cost effective for a single per site way to do it. Of course, it's never going to replace like clinical testing. You're always going to need that for your individual kind of information, but as a cost basis, it's not very high.
Yeah. And then super quickly, Are these methodologies being used in congregate settings, whether it's correctional facilities or nursing homes, universities, et cetera?
Yeah, it's actually been, yeah, it's not something I talked very much about, but it's been used pretty extensively in the dormitory settings, in universities, residential facilities, like you mentioned, congregate settings like prisons. And we have some experiences of those here in California as well. And they're very promising. I think it's can be really helpful to either augment or supplement screening programs, or to let you know that something is going on and have that trigger further testing.
Great. Thank you. And Carol, unfortunately, I'm going to probably have to end with you, but you've been doing so much work in schools, and I wonder if you can comment on two things. One is this dog work is so exciting, but in reality, how long is it going to take for this kind of really cutting edge work to be actually utilized at more scale in settings like schools? Is that going to happen within a year, or is that going to be a long way away? And then finally, if you have any comments just about how the testing, state kind of testing in the schools is going, and how kids are doing in schools.
So I would say, we really had to figure out how to do it and how to train them, but we've already feel like we could scale this up very, very quickly, very quickly. I mean, we learned a lot. We made a lot of mistakes. We're certainly learning from other partners, but we feel like we could scale it up if there's a will and there's funding for it. I wouldn't happen tomorrow, but I really feel like we could scale it up very quickly now that we've sort of done the proof of concept. And so it didn't exactly answer your question, but we could have the dog go to several schools in a given day, and I think it could be scaled up very quickly.
Amazing. And just quickly, how is testing going in schools, and how is it evolving now that we're sort of maybe moving into a new phase of this pandemic?
Yeah, that's a great question. I mean, we know that the over-the-counter tests, which a year ago were not available when we were putting this together, that will solve a lot of issues. I mean, it's certainly hassle-free for the schools, the parents prefer it. Although there seems to still be somewhat of an appetite among school leaders to have, at least in some of the schools, to have testing on site with the professional kit. So we suspect that it's going to be a mixture of the over-the-counter at home with a little bit of testing at the schools. I do think for the most part, it'll be shifting from PCR to antigen for schools that aren't already there. For the most part, there will always be a bit of a mix, but we're hoping that dogs will play an important role in that mix in the future as well.
Yeah, well, I hope so too, and I'm sure the kids do. So I wish we had more time today, and thank you to all the audience who are staying on an extra few minutes to hear from these amazing speakers. Really such an honor to be here with you. And so I want to thank you, Erica, Alex, and Carol. And then just to tell everyone, we'll be taking a break in June. So our next session will be Tuesday, July the 12th. And the information is always available, including this and other recordings of previous sessions at covidroundsca.com. And if you want CME, do that survey today, okay? Thank you, and everyone, and have a great day.
Bye-bye. Thanks.